Okay, I think we'll go ahead and get started, and then hopefully people will catch up as they join. Hello, everyone. Welcome to today's webinar on using evaluation findings. My name is Tanha Patel. I'm a Senior Technical Advisor with the CDC Foundation, and I'm here with Haley Chase and Joy Henry, who are helping me behind the scenes, and you may see them pop up here and there. Today's webinar is the fourth webinar in our webinar series, which was focused on evaluating a PQC quality improvement initiative. So thank you for joining us. We wanted to start the webinar by acknowledging that we are not able to turn on videos. We heard feedback from you all that you want to be able to see each other, but the way that Zoom is set up for us right now, we can't allow for the videos to be turned on for the participants. But I would like you guys to use the chat feature to share your name and organization if you feel comfortable sharing that with the rest of the group. We have about 27 individuals on the call right now, but feel free to type in your name, your organization to share with others who you are and that you're attending the call. I also want to make sure that we minimize distractions as much as possible. Feel free to ask questions as they arise and use the Q&A feature, if you will, of the Zoom so that we can keep all of the questions separately. And I'll get to the questions towards the end of the call. Also, we're going to be able to share a copy of the slides and the recording of this webinar on our website as well. Haley will drop the link in the chat once we kind of get all the names carried in before you lose the link. So we'll just wait a minute to send that out. Just a quick refresher for everybody. Evaluation is an iterative, data-driven process to collect evidence to answer questions you have to drive initiative improvement. A planned and purposeful evaluation helps inform decisions and provides a better understanding of what is expected of our initiatives, and it also helps demonstrate if and to what extent the initiatives are functioning as intended. Throughout the four-part webinar series this year, we've discussed that evaluation is done through four major steps. You start with defining what you can evaluate, focusing the evaluation on one component of the program or initiative, and gathering evidence of what is working or not working. Today, we will spend most of the time discussing the final steps of summarizing and using your evaluation findings. Before we get started, we wanted to share a fictional example PQC that we will follow throughout the webinar. For those who have attended the previous webinars, this may look familiar to you. This diagram of our fictional example PQC shows that the PQC has three different initiatives: a hypertension in pregnancy initiative, a substance use disorder initiative, and an obstructed hemorrhage initiative. In webinar two, we kind of talked about which of these initiatives do we prioritize, and we used evaluation standards to focus on our evaluation on the hypertension in pregnancy initiative, in particular on the comprehensive care plan portion of the initiative. If you were not attending the webinar two webinar, the link to the webinar is on our website, which Haley pasted in chat, so feel free to check that out later. During webinar three, we then decided that we wanted to understand to what extent hypertension care plan activities are functioning as we plan to do so. And we also wanted to capture that information using a document review of training webinars hosted. We wanted to do an audit of patient records to see how many care plans were actually being developed by each site. And we wanted to understand the percentage of eligible patients with care plans developed at those sites. In addition, we wanted to do an interview with site leads to hear about any adjustments that were made to care plans or the implementation of the plans themselves. We also wanted to understand what barriers exist to adhering to care plans, and this was done through a clinician survey where clinicians shared number and types of barriers they faced to care plan adherence, as well as the barriers that were faced by the patients as they were trying to adhere to the plans that were provided by the clinicians. Furthermore, site leads also share their observations of the barriers that they noticed clinicians were facing. Today, we're going to be picking up here with this example, and we are going to discuss what to do with the data that we've collected and how best to use those evaluation findings. One of the key components of using evaluation findings is understanding which partners are interested in evaluation and how they will be engaged in evaluation. Partners really do want to be engaged throughout the evaluation from the beginning of the evaluation project. This type of engagement provides an opportunity to keep your partners informed on the purpose of why you want to do the evaluation and the importance of doing the evaluation, while it also gives them an opportunity to provide their recommendations on what would be most helpful for them. This in turn will help ensure that evaluation findings are relevant to their needs, and they will be more likely to use the findings in practice, which is the whole goal of doing an evaluation. Engaging partners from the beginning will also show them that you are committed to providing the programs and improving them and sharing the learnings with others. Partners who may be interested in evaluation are those implementing the initiative, leadership of the initiative, and the organization, and those providing funding and resources. Sometimes it may be same as your organizational leadership, your board members, or you may have external funders. Your patients and the family members and caregivers are also interested in making sure that the initiative is achieving the strong outcomes that you want to achieve. Other collaborators in the field of maternal and child health, such as other PQCs, your nonprofit organizations, hospital associations may also be interested in seeing which initiatives are being successful and which are not working out. They try not to reinvent the wheel, right? So you guys want to learn from each other and apply the initiatives that are working more broadly. So in the earlier stages of evaluation, your partners can be engaged by asking them their input on what should the evaluation be focused on and why, and how should you do it. Some partners may already have data that they're collecting, and if they have that information, it'll be easy for you to kind of utilize those information instead of having to collect new information again. While other partners may also have access to individuals whom you want to engage to collect the information. So for example, if you want to understand the needs of caregivers, you can ask one of your partners who is working with caregiver population to help you send out flyers or surveys or just communicate information that is coming out of your program or your evaluation. Partners play a role in dissemination and utilization of data. But before that is done, we have to make sure that the evaluation is leading to justified conclusions and recommendations. Once evaluation data are collected and we have engaged partners in doing that, we must analyze, synthesize, and interpret the data to develop recommendations. And in order for us and our partners to utilize the evaluation findings, we have to ensure that the findings and conclusions drawn from them are justified. This means that the evaluation findings answer the evaluation questions that we set out to answer, takes into account the context of the program and the organization, and considers the contexts in which the data are collected and participant situations. It engages partners in making sense of the information and getting their buy-in on what the data are suggesting. The first step in justifying conclusion is to systematically start making sense of evaluation data that has already been collected for each of the indicators that the evaluation questions is aiming to answer. This is when the data is described or summarized. It's not when we're drawing conclusions. That comes a little bit later. To do this first, the data collected should be reviewed to make sure that they are accurate. Sometimes you may find that the questions being asked are very vague, or respondents are not sharing the information that you really wanted to hear from them. So you may have to review a little bit of the data coming in early on to see that you are getting what you really want. to get from the participants. If you are not getting what you want and you need to clean up the information, you will have to do that next. Once you have cleaned the data, you want to start sorting the information into categories or groups of responses. For example, look at how a certain question was answered by individual demographics like race, ethnicity, age, or gender. You can also look at site characteristics. For example, you can look at the NICU level, the births per year at a particular hospital, or perinatal variables like mode of delivery, maternal age, gestational age. All of those could be grouped together and categorized to look at information. If you have location, you can also look at responses based on individuals that are in urban area versus a rural area. So by creating these categories and groups, you will learn more about who's actually providing you with this information, and it will also highlight any gaps that may exist. This is one of the first steps to kind of understanding the equity and the diversity of the respondents that are coming in and the people who are actually providing you with information. So doing these types of summaries for each set of data that you've collected separately will start helping you make sense of what all is happening within your organization, within the initiative, or within the hospital system that you're working in. One thing to keep in mind when creating these groupings is to make sure that you're still maintaining confidentiality. That is really key, right? If you have less than 5 responses for a group, don't try to summarize or report on that, because it may be small enough in your area that someone could identify that individual. So try to follow the same guidelines and best practices for kind of maintaining confidentiality and protecting the privacy of the respondents. You can also start visualizing this information through tables and charts or quotes at this point, and these visualizations will help identify trends quickly. And if you remember, there are 2 types of data, quantitative and qualitative. Quantitative data are more numeric. So generally, quantitative data is often analyzed using descriptive analysis. Descriptive analysis is a process of summarizing and describing the data that are collected to highlight emerging trends and patterns. For most evaluation questions, descriptive analysis of where you report on distribution for responses through commonly used measures is enough. And I'll walk through some of the commonly used descriptive measures. So the first one we have is count. Count is the total number of instances that something occurred. These could be individuals, events, or characteristics. We also are used to percentages. Percentage is when you're showing a numerical relationship between 2 or more groups. For example, percentage of pregnant people with type A diabetes out of a total number of pregnant people admitted in the year. We have mean or average, which is a measure determined by adding up all the values and then dividing by the total number of units. Median is the middle value in a set of numbers after you sort them from lowest to highest. And if you have an even set of numbers, median is the average of 2 middle numbers. Mode is the number that shows the lowest and highest possible, or actually that is range. Mode is the number that is reported the most often in a set of data. Range is the measure that shows the lowest and the highest possible numbers reported. Sometimes you may need to do advanced analysis or statistical analysis, especially to describe trends and make predictions by testing 2 or more variables. This is only required if you're doing advanced analysis for outcome or impact evaluations. In general, though, simple descriptive analysis is probably what you need, and you can do that easily on Microsoft Excel or Google Sheets. You may also find that visualizing your quantitative data through tables, charts, maps can help with synthesizing and interpreting findings. Graphically showing the data can help people read and understand the information better. You can start seeing trends and gain valuable insights by seeing how a data relates to another data points. So we have an example here on the slide where the table is comparing percentage of eligible patients with care plans developed across 3 different hospital systems, Hospital A, Hospital B, Hospital C. You can see that the percentage and total number of eligible patients in the table. Although the number of eligible patients is least in Hospital B, the percentage of those patients with care plans developed is the highest. This is clearly visualized in the chart to the right. The chart, if you skim it, you get the point that Hospital B has the highest percentage of eligible patients with the care plan. But one thing to keep in mind is what's really important for you and your team to understand. Is it that the percentage of eligible patients having care plans developed is more important? Or do you care more about how many care plans are developed in total? If the team cares more about the total number of care plans developed, you want to create a chart for the number instead of the percentage of eligible patients. Doing that will show you that Hospital A has the highest number of patients with care plans developed because they are the biggest hospital with highest number of eligible patients. So it makes sense, right? They're the biggest, hence they would have the highest volume. But if that's not what you care for, then you need to think about the percentage. So the other type of data that you may have is qualitative data, which are more contextual, more narrative information. And analyzing qualitative data generally requires thematic analysis, which is a method for systematically examining qualitative data, such as interview transcripts, to identify patterns on what is actually being shared. This analysis will involve a step called coding, which is the application of codes or labels to your data. A code is 1 to 2 word label used to help identify larger themes in the data related to your evaluation question. Oftentimes, you may want to create a code book to make sure that you're consistently applying the labels throughout all of the data that is being collected, and you're being subjective. You're being more objective and reducing the subjectivity, excuse me. Because of that, you may also have 2 coders code the data, because if you have discrepancies or differences in opinions, the 2 coders can talk it out and kind of come to a middle ground before you move forward to your recommendations. So once codes are applied to all of the information and the differences are resolved, larger themes that appear repeatedly throughout the data can be identified. And once all of the themes are identified, descriptive analysis is conducted to understand which themes come up the most, by whom, and what is the context around each of the codes and the themes that are bubbling up. Qualitative data can be analyzed in Excel or even in Microsoft Word. But if you really have a lot of data to analyze, or if you need something more advanced, there are softwares like MetsQDA or NVivo that could be used as well. And you could also hire a qualitative data analyst if you really need to, but most of the times you may not need to do that for evaluation purposes. You can also visualize the qualitative data to help kind of make more sense of the information that you're collecting. For example, the most common way to visualize qualitative data is directly pulling the quotes from your participants. Whether it's survey, interview, or focus groups, it's going to be good to share some direct quotes. This data visualization can be made more effective if you bold the text that is important to highlight, or italicize or change the color like we've done in our example. One thing that you should pay attention to when you're pulling quotes is to make sure that the quotes really resonate with what the themes and the recommendations are being presented in the report or the slides that you're presenting. You don't want to share a quote that's very vague, and it's hard for the reader to kind of understand, how does this quote relate to this theme that they're talking about, right? So you want to make sure it is consistent. Another way to visualize qualitative data is to simply add icons or images that represent the content of the findings. For example, in our slide, we have icons, and quickly, if you just scan through the icons, you can see that we're probably talking about laptops or technology in the first one, time-related finding, and people-related finding. If you read the text, you can see that the first laptop is talking about document the care plans using current electronic systems. The second one is spending more time, and then the third one is being encouraged by a peer. So it kind of relates the messaging with the visual icons and the images that may be used. You can also use word clouds. Those are really popular these days. Diagrams, photos, or timelines are other commonly used visual things for qualitative information. So you may be wondering, oh my God, that is a lot of technical stuff. Who is supposed to do this? Who's supposed to analyze the data? But really, anyone can analyze the evaluation data. As I mentioned earlier, most often only descriptive analysis is required to report on evaluation findings. So someone familiar with the initiative or the evaluation that was conducted is going to be an ideal member of the team to conduct the analysis as well. All you really need is basic math and calculation skills. So as long as you can function in Excel or Word, I think you should be fine. It's only when you have to do a more advanced or large volume of data, then you may have to hire a trained analyst if you don't have one on the team already. But I think anyone can really summarize the information. So once you collect all the information, once you've started summarizing that information, the next step is to synthesize that information to where that you take the basic summary that you had and you create that for each data collection that you've had and you bring it together. So as shown in this visual here, you have data from one data collection, maybe a survey, you have something from interviews, you kind of bring those together and try to see, okay, what are they actually telling me? Oftentimes, we are going to be using mixed methods and multiple data methods. So this is a very important stage where you will try to bring everything and try to make sense of the bigger picture. So in our hypertension example, we used patient record audits, interviews with site leads, and clinician surveys to understand the extent at which the care plans were being implemented and what barriers were existing that were making it hard for clinicians and patients to adhere to the plans, right? So during the synthesis phase, we're going to be looking at what is consistent across the findings that we got from these three data collection methods. So let's walk through two examples together. In this first example, we see that in patient records, we're noticing that hospital A has the lowest percentage of eligible patients with patient records. We also see that clinicians from hospital A identified a lot more barriers than other participating hospitals. And site leads also share that they had a hard time getting leadership buy-in to prioritize the care plan implementation. This is showing some alignment in the findings. It's showing that hospital A needs more leadership buy-in and they face a lot of barriers. And maybe that is the reason why they have a low rate of care plans among eligible patients, right? So you see similar themes bubbling across all of your data collection methods. In this next example, we noticed that hospital B had the highest percentage of eligible patients with patient records. But the site implementer told us during the interview that they're having a hard time getting leadership buy-in to implement the care plan in practice, which is similar to hospital A. But this is contradictory finding. That's now suggesting that something is off. In this case, it may be necessary to double check the data to make sure there was no error. And Joy, I think we lost screens there. Sorry about that, guys. Joy, do you want me to go ahead and share my screen?
Apologize. My screen went black for some reason, so the presentation is black at the moment. So if you're able to.
Yep, I can do that. Give me just a second. Let's pull it up real fast. And then do you guys see my presentation now?
Looks good.
Awesome. So I was just talking about the hospital B having the highest percentage of eligible patients with records having the care plans. And in contradiction to that, the site leads were saying they didn't have leadership buy-in. So we want to make sure that data is actually correct before we do anything else. And if there is no error, and then we may want to check to see if the clinician said anything that would help us complete the picture. So by talking to the clinicians, you may find that clinicians are really invested in their patients and want to start implementing the care plans. So they are utilizing the care plans on their own while the leadership is kind of deciding what to do with care plans. So this is now, although there are differences, there's some similarities bubbling up. And having the multiple methods is showing you what's really going on, is that clinicians have really drank the Kool-Aid and they're taking on the care plans on their own. And that's why you see a high percentage of patients with care plans. So as you start looking at the common themes and contradictions between data sources, you'll start making sense of the information that's coming in. So you'll start seeing what information means for you and your program. This is referred to as interpreting the findings in more technical terms. During this stage, you should engage partners to make sure that your interpretation of the findings resonates with them, right? The partners will help you decide what is meaningful and what is going to be useful and what's really missing from this information. And so if you remember, I talked about engaging partners for the caregiver example. So if you go back to that example, your partners may have helped you send out the flyers to recruit for caregivers for an interview or a focus group. But when you have the data, you may want to go back to that partner, that organization, and kind of share the initial findings with them and see if that resonates with them, because they work with caregivers more on a daily basis. So they may be able to provide you with context as to why certain themes are bubbling up or what is really going around the caregiver space that may influence the responses that you got. And so engage your partners in understanding what are the results and the summaries really telling you. And this context is going to be really important to have as you start making comparisons to findings to other data that may be available outside, right? If you're comparing your data without the context of what's really going on, you may not be able to compare it apples to apples. You may be doing it apples to oranges, which might not be the best idea. So what does interpreting your data look like? And I want to walk through this with a few examples together, and we'll use our hypertension care plan example together. We've created some fictional findings and interpretations for this webinar, so it may not always resonate with what's going on the ground, but I think what we'll do is we'll engage you in 3 of these examples, and I'll present the relevant data, and then I'll tell you to kind of process it and then type in your reactions using chat. So let's start with the first one. So in this example, our patient record audit revealed that only 60% of the eligible patients across 3 of the implementing hospitals had care plans. We saw that academic hospitals had the highest percentage of eligible patients with care plans. Also, the clinicians reported in the clinician survey that they were unable to spend time on developing care plans with patients because the patient visits are so short, and adding this added step was just taking too much time for them. At the same time, they also noted that clinicians, when they did spend time with patients, they were able to explain the risk of hypertension in pregnancy better. So what can you interpret from these findings? And feel free to chat in your thoughts on that. I'm taking a water break. Anyone have any ideas? No, maybe I'll do this one and maybe we'll have more people chime in the next time. So using the findings, we can make interpretation that limited time with patients is a barrier to developing patient care plans, right? We heard that from the clinician that it was really a barrier, and maybe that's one of the reasons why the rate is not as high. In the second example, using the same situation, where we had 60% of eligible patients across 3 implementing hospitals having care plans developed. The clinicians in the clinician survey shared how difficult it was for them to document care plans using the current electronic charting system that was in place for them. Clinicians from the academic hospitals, however, had a higher rate of eligible patients with care plans. They did not share this barrier because they were using a different electronic system. Thoughts on what interpretation we may be able to make from this slide? And then feel free to use chat. There's really no right or wrong answers, right? Yeah, Carly says EMR system impacts the documentation. That's exactly it, Carly, right? These findings can be interpreted as technological challenges being a barrier to clinicians developing care plans for eligible patients, at least in the non-academic hospitals, because for those in academia, they have better systems, or they may have different systems and more resources available, so they may not be facing the same technical challenges as the others are facing. One thing to note here is I left the interpretation a little bit broader, because when we go down and talk to the partners, we may identify the contacts around it. So we may know one particular system is a barrier, or, we may find more details later on. So keep it more high level if you can. In this next example, looking further into the patient record audit, the data revealed that patients who spoke English as their first language were more likely to have hypertension care plans on file compared to patients with other than English being their first language. And findings from both the clinician survey and interviews with site leads reveal that clinicians found it difficult to develop care plans and discuss them with patients from migrant and refugee backgrounds. They share that language barrier slows down the already short visit, and it was difficult to explain the technical, more challenging health topics across the language and cultural differences. And some patients were resistant to medication altogether based on their cultural preferences. So what interpretations can be made from this? Yeah, Rebecca says language barriers for non-English speaking patients impact care plan development. Yeah, you're spot on. So using the findings from the 3 sources, we can make the interpretation that cultural and language barriers impede patients from having care plans and being able to follow their care plans, right? It's both from patient perspective and clinician perspective. They're both seeing the barrier in adhering to their care plans. And here we have both quantitative data and qualitative data showing the same disparity and the same barrier, right? So again, mixed methods, different types of information is really going to be important for you to have. So after completing additional interpretations, we see that hypertension care plans are not being implemented as well as intended across the participating hospitals. We saw that only 60% of eligible patients across the 3 hospitals had care plans. And we also saw that academic hospitals had the highest rate of eligible patients with hypertension care plans. Also, the most significant barriers to clinicians implementing care plan activities were their limited time with patients, their technological challenges with documenting care plans in their EHR systems, and the cultural and language barriers between patients and clinicians. So if you remember the 3 questions that we started off answering, it's all answered on this example key finding slides, right? The question was, are the care plans being implemented as we intend them to be? And what are the barriers for implementing those things? So going through the data analysis, synthesizing, interpretation, now you have key findings that are starting to answer your questions. So what do we do with the answers now? So the next step is to use the findings and try to identify what action can be taken. To do this, we must use data to generate actionable recommendations. The actionable recommendations are going to help us improve the implementation of the ongoing initiatives. So our key findings may describe what the initiative did, how well it did, and what was learned from the evaluation. From your findings, you can create actionable recommendations that are data-driven actions that suggest, based on interpretation of evaluation findings, what can be done, who can make that change, and what will those changes lead to. If you conducted a formative evaluation, the recommendations would speak to how the program should be developed or refined. If you conduct a process evaluation, the recommendations will speak to how the program can be improved, whether it means reaching new audience, new populations, or updating or refining the process of implementation. This is where our example sits right now, right? It's in the process mode. And at one point, you will want to do an outcome evaluation. And if you do that, the recommendations from that evaluation will speak to how a program should be continued, discontinued, scaled up, or if you need additional resources to continue the strength of the outcomes that you're seeing. So when thinking about translating data into action through actionable recommendations, it's important to keep in mind who will be most appropriate to act on the recommendations that are bubbling up from data. Think about what they can do in regards to the findings or the recommendations, why they would even care about the findings and recommendations, what's in it for them, right? And importantly, how should you share the findings and recommendations with them so that they buy into the findings and they actually do something about it? So returning to our hypertension care plan evaluation findings, let's walk through how we may translate some of these findings into strong actionable recommendations for the initiative design and implementation team. So first, for our finding that clinicians did not have enough time with patients, we could recommend that the initiative lead should engage hospital obstetric leadership in streamlining processes and increase the amount of time they can spend with patients. Now, I know what you guys are thinking. This is not easy, but this will impact the number of patients the clinicians can see in a day, right? And therefore, it's going to be really important for the leadership to consider care plans as a priority. And you need to communicate with them and recommendation that is actionable with some options of how do you actually do this. For finding that technology challenges were also a barrier, there are a few actionable recommendations that can be proposed. So first, the initiative team can work with the IT department to better integrate care plan templates into visit workflow by creating pop-ups for patients who don't have a care plan in place already. So it's not bubbling up for everybody, but tailor it to those who really need it. And the team can also then provide training to clinicians on how to utilize care plan templates during the patient visits. Finally, for our finding that cultural and language barriers affect care plan implementation, one recommendation that we can make is that initiative team translate standard hypertension in pregnancy materials in languages commonly used by patients at each of the hospital sites. So if you have Russian-speaking population in one hospital, then try and translate it in Russian for that hospital, but another language for another hospital. We could also make high-quality interpreters available at each visit to allow clinicians to easily communicate with patients. These are all examples that we've come up for a fictional example, and I understand that it may not be as feasible for many of you, but I just wanted to show you the process of going through collecting data and then coming up with data driven recommendations. So forgive me if they seem really bold, but just wanted to do it for illustration purposes for now. For tips in building your data-driven recommendations, make sure that your strong recommendations are objective and strive to keep personal bias in check. It's really easy for us to bring our personal opinions to the table, so I always have to put another hat on and say, okay, this is me hat, this is the evaluator hat. What are we actually seeing in the data and what are the data telling us? It's also important to keep context in mind, and we have to anticipate concerns. Like I mentioned, you were probably looking at me like, oh, these recommendations are great, but I can't really do that. So keep those concerns in mind when building recommendations and make sure that recommendations are feasible and that you can tot your recommendation out with your partners and your stakeholders to solicit reactions and feedback from them early on. And then present recommendations more as optionals recommendations, and then keep it open for a conversation on what actually can we do if not this. And then finally, communicate your recommendations with those who can actually act on them. So if the recommendation is for a leadership level individual, talk to the leadership. Don't just share it with the teammates because they won't be able to do anything about it. When it comes to communications, evaluation findings and recommendations can be shared in many different ways that are suitable for different audiences and contexts. For example, if you want to share your evaluation findings with leadership, you may want to do a quick one-pager or a project summary that they can quickly glance at and give the key takeaways. This one-pager may not be that useful for your patients or caregivers, though. For them, you probably need to have a different communication style and a different product altogether. So for your evaluation, you're probably going to develop multiple types of communication tools to share different recommendations to the different audiences and partners. So it's really important to tailor each communication material to the audience and to the partner to really get their buy-in to complete the action that you're asking them to do. I think with the next slide, I want to do a quick activity with you all. I know you guys like the activity, so we wanted to make sure we made time for one of them. Haley is going to open up a Zoom poll for us. And with this activity, we're just going to quickly walk through different audiences, different individuals, organizations that we may want to share evaluation finding with. And you can pick the best way to share their information for that particular audience. So just take a few minutes and complete the poll and we'll come back together. And then there is no right or wrong answers here, so this is just more of a practice for us to talk through. Give it one more minute. Okay, Haley, can you go ahead and end the poll for us, and I'll walk through the responses with everyone. Perfect. So for birthing people in the state, you want a product that will reach a large number of people with a simple message, right? So social media campaign is probably going to be a best choice. For the participating hospital, a project summary would probably be the best way to communicate findings. That's more feasible. For other perinatal program implementers in the US, like yourselves, a conference abstract, a conference presentation, or a webinar is probably going to be ideal to reach the broad, diverse group. And finally, sharing findings with your PQC quality improvement team, just an internal presentation is probably going to suffice there. Or an email communication may work, a newsletter may work as well. Great, thank you so much for participating in that poll for us. And that is really a good way to wrap up our webinar on how to summarize and use evaluation findings. This was the last webinar in the series where we have shared what is evaluation, how can you complete the 4 general steps of evaluation to evaluate one or many components of your QI initiatives. There's so much more we could be talking about for evaluation, but for this year, I think we've given you enough. We are here for taking questions. So I know in chat, Haley has put in, if you have questions, feel free to use the Q&A feature. And we do plan to continue providing evaluation technical assistance over the next few months. So if you have any recommendations or burning questions that you would like us to address, please feel free to share those with us. And then really quick reminder for those funded by CDC, you still have 1 office hour left in June 11th at 1 p.m. So if you do want to join and ask some questions at that point, feel free to do that. You will have the registration information on our website, and we will be sharing the slides and recording as well on our website that Haley just put in chat for you. But with that, I really want to thank you guys for participating and joining this webinar and the prior 3 webinars with us. I'll transition to questions real quick. Before I do that, quick reminder that we will send out a survey at the end of the webinar. So please take a minute and share, what about evaluation are you still confused about? What else can we share? Do you want more practice, more examples? What exactly would be helpful for you to start doing evaluation of your QI initiatives? So I am going to pause there and open up for questions. Feel free to use chat or Q&A at this point if you have questions, or if you want to talk, feel free to raise your hand and we may be able to allow you to speak. Thank you again, everyone. Haley, do we have any questions online?
We did not get any questions while you were speaking. So the floor is totally open. Looks like people are heading out for their next meeting. We still have a few people on. So if you're staying on, if you have a question, it's a smaller group now. Feel free to pipe up.
I'm going to stop sharing. Do we have any questions in the group? If you want to raise your hand and share. Yes, Julie, the series was recorded and it will be available on our website. The prior 3 webinars are already posted, but this one will be posted in the next week or so. And there's also PDF of slides if you don't want to spend the whole hour to re-listen to the video. You're welcome. If you guys don't have any questions, I can let you guys go. Thank you so much for joining the webinar. And if you have any questions, feel free to email us as well.
All right, so I'll close the webinar. Thanks, everyone.
Thank you. Bye.